as said, my name's Dr. Jacob Baker. I'm an undergraduate medical graduate of Keele, and I studied microbiology in Manchester. I'm now working as a foundation doctor in the Shrewsbury Trust in the UK, and I'd like to share our strategy with you in that hospital as to how we dealt with the COVID outbreak. So just a quick introduction. We're going to talk about our cohort strategy that we used in Shrewsbury. We did an audit into the effectiveness of that strategy, and I'm going to talk to you about how we're moving to improve that strategy and hopefully about how it will be possibly effective in other centres. So the situation in RSH in the Royal Shrewsbury Hospital. So we're a district general hospital in Shropshire, which is a rural part of the UK, which serves about 500,000 people. We had a lot of problems at the start of the coronavirus outbreak here in the UK. Due to lack of in-house PCR testing, we were reliant on the nearby tertiary centre, so could have to wait up to 6 days for a result to come back. And given that we're quite an old hospital building, we had a significant lack of single patient isolation rooms. So we had a significant risk of in-hospital transmission of COVID. So we developed a mitigation strategy to try and reduce our rates of in-hospital COVID transmission, which was based on stratification of patients on admission as to how high suspicion they were of having coronavirus. Starting with people who were high suspicion of having coronavirus, then those who were suspected but a low suspicion group, and patients who were not suspected at all. So I've developed a little graph to walk you through that. So the decision was made at post-take by a senior medical practitioner, either the medical consultant or the senior registrar if the consultant wasn't available. So the no suspicion patients would be placed into the general medical population. The high and low suspicion patients would be placed into bays full of patients of the same level of suspicion, on the hopes that we could cut out and place only the positives in the high suspicion group and hope that most of the low suspicion group would be negative. There they would wait their swab results. With positive patients, it was relatively simple. They were moved to a positive bay. And it's the negatives where it became complicated. With the negative patients who had no negatives at all in that bay could be safely placed into the general medical population. But the negatives in which the bay included at least one positive patient meant that those negative patients became contacts. So we had to create contact bays where we had to monitor those patients for any signs of symptoms, given they had had quite close contact for an extended period of time with coronavirus patients. We realized there were flaws in the system from the start. We were at risk of overestimating patient suspicion and putting that patient at risk, or underestimating patient suspicion and potentially exposing others to risk if they turned out to be positive. Poor accuracy in the process led to a large number of contact bays, which is a bed management nightmare, as I'm sure you can imagine. So why did we have these issues? We had no clear labeling as to what constituted high or low suspicion. It was down to the individual consultant. And there was a lot of fear over missing a COVID case, which led a lot of consultants to overestimate the suspicion of COVID in a patient. Especially some were unwilling to label people no suspicion. So I took to auditing this strategy to see how effective we were actually being. I logged every single query COVID admission to the hospital over a certain time period, noted their stratification of their risk, and then followed up their swabs to see how good we were at actually telling who had COVID and who didn't. So looking at our results, they were in some ways positive, in some ways good, in some ways bad. We had a split of 46 patients being high suspicion, 27 being low suspicion during the time period I studied, and you can see the numbers there for yourself. Of the high suspicion group, around a third were positive, and of the low suspicion group, only 7% were positive, which shows there is a clear statistical significant difference between our ability to differentiate high and low suspicion coronavirus cases, but obviously leaves a lot to be desired in terms of how accurate we're being. So overall positivity of 23% in the entire population that we studied. So we feel our findings have contributed somewhat towards the evidence that clinicians can unaided diagnose COVID-19. However, there's obviously a lot to be desired in terms of aiding clinicians in their ability to rapidly diagnose COVID before a swab result comes back. So we've already started to take steps to improve our process, such as trying to reassure clinicians through email that it's okay to label a patient no suspicion COVID. It doesn't constitute a view that the patient certainly doesn't have COVID. It just means when they present to hospital, they've got no signs of having COVID, which is all you can really do at the time, is that you use the information you have. So moving forward, we're looking to try and create better guidance as to what constitutes high suspicion. And we're looking to try and use cheap and readily available tests that can be done immediately on admission to try and aid consultants in judging who has COVID and who doesn't. So the thing the Trust is looking into at the moment, and we're currently doing a 2-week data collection program on our query COVID patients, is their admission AST and LDH blood tests, which is based on some quite promising positive predictive values and negative predictive values at certain parameters that those blood tests provided, showing that they correlated with swab positivity, which came out of some data from Ferrari et al. In Milan, and was supported by the outbreak data from Tehran as well. You can see that data for yourself there in terms of using certain parameters you can see here on the left with LDH and AST, some very high positive predictive values of swab positivity that were generated. So we're hoping to use those in our own cohort strategy going forwards. But there's a reference to that at the end, and I'll leave you in your own time to look at those people's works. So we believe this could be quite relevant to other hospitals, especially those in poorly resourced hospitals or in developing economies, where PCR testing takes a long time to come back or isn't available at all, or where individual side rooms aren't really available at all. So to conclude, I think we can say that in-hospital transmission of COVID is quite a big deal. It's supposedly 20% of people who have caught COVID in the UK caught it in a hospital. And therefore, any strategy that a hospital can implement to reduce in-hospital transmission is very, very useful indeed, especially in a hospital which lacks the ability to isolate patients individually and the ability to get very quick results from PCR testing. So here's the references I've mentioned, and thanks to some of my colleagues who helped me. My email address, if any of you wish to contact me about this, I'd be very interested to hear from other clinicians and other hospitals about what isolation strategies they've had for their coronavirus patients, especially when they lack side rooms to be able to put each individual query COVID patient into a side room. So thanks very much for interesting.